Hi.
Michael.
Good to meet
I'm
you.
going to introduce myself.
Okay. All right.
We're pleased to have Dr. Pappert, who's new faculty member in the Division of Neurology in our Department of Medicine, to speak to us today on treatment of early Parkinson's disease. And it is a pleasure to meet you, and I look forward to working with you.
Good. Thank you.
Glad you're here.
Thanks. All right. As stated, we're going to talk about the treatment of early Parkinson's disease, and really I think that's applicable because more and more, and certainly in your area of expertise, you're going to see patients with Parkinsonism and idiopathic Parkinson's disease that there's much in the literature debating what is the appropriate initial treatment. And since you and the internal medicine specialists are seeing these patients before they're referred to neurologists or movement disorder neurologists such as myself, it's important to help guide you make the correct decision based on the research that's available today. Why should you care about the treatment? Why not just start Levodopa? The patients do well, they have a robust response, and they'll be happy. Why not just follow this old mantra of treatment? Well, first it's important to understand what the treatment goals and the expectations of the effects of therapy should be in patients that you're establishing a diagnosis of Parkinson's disease. It's also important to establish a proper mindset and habits from the beginning of the disease, since patients will have certain expectations of what the treatment should do, and you need to help guide them so that they are not having expectations beyond what therapy beyond what the therapy actually can produce and what you should be attempting to produce with therapy. And finally, it's important to recognize that early treatment has profound influence on the development of adverse effects of medications, both motoric effects as well as behavioral and psychiatric side effects. Well, there are four main aspects of early treatment in Parkinson's disease. Obviously, the first is to establish a proper diagnosis. And when faced with Parkinsonism, it's important to recognize that that merely represents the presence of four main features. First is bradykinesia, or slowness of movement, which can encompass the ability to arise from the chair, activities of daily living, depressed facial expression, low volume of voice. All are examples of bradykinesia. Tremor predominant at rest is the characteristic sign, but it's important to recognize that only 80% of patients with idiopathic Parkinson's disease ever develop tremor at rest, so its absence does not exclude the diagnosis. Rigidity or an increased resistance to passive movement is something that you would recognize on your direct examination. Patients aren't going to complain of this. They'll complain of stiffness and slowness, which is really a factor of bradykinesia, not rigidity. And then finally, loss of postural reflexes. And you must not have all four of those cardinal features to make a diagnosis of Parkinsonism and then idiopathic Parkinson's disease. You must only have two of the four, as long as one of the two is either bradykinesia or tremor predominant at rest. And it's important to recognize that distinction and the accepted criteria for diagnosis. Whereas idiopathic Parkinson's disease is the most common cause of Parkinsonism, it's important to recognize secondary causes, especially drugs, and more and more with the use of metoclopramide, I see many more cases of drug-induced Parkinsonism. But of course, all the other typical drugs can also cause the signs and symptoms. Things that you may not consider as causes of Parkinsonism include lithium, Depakote, all need to be considered, and certain calcium channel blockers. And of course, encephalitis, rare cause of Parkinsonism. And then the other Parkinsonian syndromes, which have the features of Parkinsonism, but other components of the in the examination and history. Clues that should tip you off to a diagnosis of idiopathic Parkinson's disease include the asymmetrical onset of symptoms, which is much more common in idiopathic Parkinson's disease versus progressive supranuclear palsy or drug-induced Parkinsonism, and so should prompt you to think of idiopathic Parkinson's disease. Rest tremor, while not necessary for idiopathic Parkinson's disease, certainly if present is very suggestive of the disease. And a good clinical response to Levodopa should all indicate that the diagnosis is proper. Once the diagnosis is made, then non-pharmacological therapy, including education of the disease, the prognosis, focusing in on...
I think it's hopeless until they...
All right.
Let's see what's happening up there. It's just door or upstairs?
I think it's right on top of it. It's more like destruction than construction.
But I mean, I didn't know there was construction.
Okay. Well, maybe we have a reprieve. So, again, the non-pharmacological therapy is as important as what I'm going to talk mostly.
Have you been hearing this the last few days?
No, it just started.
Yeah.
To talk. They waited for me.
Marx Brothers movie.
Quick, say something.
I know. All right. Again, education, exercise, diet all need to be part of the initial discussion, but I'm not going to focus in on those areas today. Insofar as neuroprotective or neurorescue therapy, certainly if we had a definitive agent, that would be a mainstay of treatment in early disease, and any discussion about neuroprotection obviously needs to focus on the potential causes of Parkinson's disease. And again, these are all potential causes, and the etiology, while still unknown, appears to rest on a combination of both genetic and environmental factors. And in fact, 10% of idiopathic Parkinson's disease can be related to a genetic disorder, and up to the present time, 10 monogenetic disorders have been identified, characterized as Park 1 through 10, which have a variable number of genes associated with the disorder. In addition, exposure to pesticides or rural living has been suggested as a potential contributor to the development of idiopathic Parkinson's disease, And this has resulted in an interesting animal model utilizing rotenone, which is obviously a pesticide used in the environment. And rotenone has produced an animal model that is the most characteristic to date of idiopathic Parkinson's disease, even producing Lewy bodies, in contrast to the MPTP monkey model that was developed after its identification in drug abusers in California. And so a combination of environmental factors and perhaps genetic susceptibility result in the ultimate pathogenic mechanisms, which have revolved around 5 main areas, that including abnormal protein aggregation, mitochondrial dysfunction with overlying oxidative stress, contributions of inflammation with increased gliosis and microglial production in the area of neurodegeneration, and additional excitotoxicity, ultimately resulting in programmed cell death or apoptosis. And so considering the potential mechanisms of Parkinson's disease will then result in the potential neuroprotective therapies. Now, the outcome variable to measure disease progression has generally been focusing in on the time to reach clinical milestone, and up till recently most of the studies utilized the initial need for levodopa therapy. This has been done by comparing the baseline Unified Parkinson's Disease Rating Scale motor scores with those after drug washout period, utilizing a drug with potential neuroprotective effects. More recently, however, we've been utilizing neuroimaging markers, both beta-CIT SPECT and fluorodopa PET, actually measuring dopaminergic neurons in the striatal system in order to get a better indication as to neuroprotection. And
How does that correlate with symptoms?
we're going to talk about that. I just wanted to bring that up so when we talk about studies, you have an idea of what we're using for outcome variables. This is just a cartoon to inform you as to how the 2 imaging studies are utilized. The fluorodopa PET, obviously the DOPA tagged by fluoride, is taken up by the dopaminergic cells, converted to dopamine, and so we measure the presynaptic dopaminergic system through the administration of fluorodopa. The beta-CIT attaches to the dopamine transporter, again presynaptically, but at another point in the dopaminergic neuron, and it's these 2 ways that we measure whether there is additional loss of these dopaminergic cells over time, and we'll come back to that with some of the clinical studies that I'm going to go over. This is just to give you an idea of what we see utilizing these 2 modalities. The fluorodopa PET scans, here's a normal control, early stage Parkinson's disease, and as you can see, the additional loss of these dopaminergic cells in the caudate and putamen. This is a similar study, but utilizing beta-CIT, again, the normal control, and with progression, the loss of dopaminergic cells tagged on the DIT site of the neuron. A number of agents, and 7 broad types are listed here, have been considered as possible mechanisms for neuroprotection. Those include antioxidant agents, glutamate antagonists, mitochondrial bioenergizers, anti-inflammatory agents, neurotrophic factors, and agents that may prevent protein aggregation, and anti-apoptotic agents. All of these have been studied with clinical trials, and as well as the anti-apoptotic agents. To date, we have no agent to be tested that can prevent protein aggregation. The first study that was done in the late 80s, early 90s involved the then novel antioxidant agent called Deprenyl, which, as you know, is an irreversible monoamine oxidase B inhibitor. And if you look here on the schematic, the administration of MAO-B inhibitor impedes selectively the metabolism of dopamine with oxygen and water to DOPAC and hydrogen peroxide. This molecule then interacts with iron to produce free radicals, and it's this mechanism which is thought to perhaps be involved in further neurodegeneration by oxidative stress on the local dopaminergic neurons. In this study, characterized by the acronym DATATOP, Deprenyl was tested with tocopherol or vitamin E in a 2-by-2 fashion, where patients either received tocopherol alone, Deprenyl alone, both active agents, or a double placebo. And the endpoint, again, was the need for levodopa administration. This study, which was published in the New England Journal first in '89 and then in '93, demonstrated that vitamin E had no effect in disease progression, but selegiline was able to delay the emergence of disability and progression of motor signs, ultimately delaying the need for levodopa. However, as part of the study, it was found that selegiline also had a long-lasting symptomatic effect, and so this brought into controversy whether the delay for need for levodopa was a result of the symptomatic benefit that the agent produced, or whether it actually produced neuroprotective effects. Additionally, the initial benefits found with selegiline were not maintained, and patients had their best response 1 year after administration. As an extension of this study, all the patients received selegiline and levodopa open label, but 368 patients were re-randomized to receive levodopa with or without selegiline and followed for 21 months. And the group that received selegiline required lower doses of levodopa, at a slower rate of progression of motoric symptoms, and had less freezing, again suggesting to many that selegiline may in fact have a neuroprotective effect which may be outside of its MAO-B inhibition and may actually revolve around an anti-apoptotic effect, and this is the source of continued research. I wanted to bring you up to date on an agent which will be coming out next year named rasagiline, which is also a novel selective irreversible MAO-B inhibitor, and your patients will likely be asking you about this. It has a greater in vivo potency than selegiline by 5 times and has been demonstrated to have direct neuroprotective effects in cell and animal models of Parkinson's disease. These neuroprotective effects are again thought to be unrelated to the MAO-B inhibitory actions, and again suggest an anti-apoptotic effect. And at present, several studies are ongoing evaluating in humans the potential neuroprotective effects of this agent. It should be known, though, that clinical trials already have demonstrated that this agent is effective both as monotherapy, and so may be a choice in early Parkinson patients as monotherapy, especially as more and more is understood about its potential neuroprotective effects. In addition, it's also useful as an adjunct therapy to levodopa, so patients who began to have motor fluctuations or wearing off when rasagiline is added, they have added benefit to the levodopa administration. Just something you should be aware of because it will be out early next year. Moving away from the oxidative stress potential neuroprotective effects of agents, another avenue of potentially affecting disease progression is combating exocytoxicity, and this has revolved around utilizing riluzole, an agent which is approved for use in motor neuron disease and ALS. As you know, glutamate is the major excitatory neurotransmitter in the central nervous system, and a slow excitotoxic process has been proposed as a potential etiology for Parkinson's disease neurodegeneration by Beal and others. Riluzole is known to impair glutamatergic transmission by blocking voltage-dependent sodium channels, and as such had been successful in animal models of Parkinson's disease, slowing progression of the disease and the effects of toxins used to induce animal models of Parkinson's disease. However, in the limited human trials, this has not been shown to be effective in idiopathic Parkinson's disease, and so this really has been not studied any further. Also an area of interest has been replacing trophic factors, specifically glial-derived neurotrophic factor characterized by GDNF. This agent is known to promote survival of dopamine neurons, enhances the dendritic neurites and dopaminergic neurons, and increases the quantal size of dopamine in these same neurons. As a result of the bench research, animal studies with injections of this agent in the midbrain as well as into the lateral ventricle showed improvement in motor features in animal models of Parkinson's disease, as well as increasing striatal dopamine concentrations. An initial double-blind study of GDNF infused into the lateral ventricles of humans with Parkinson's disease unfortunately did not demonstrate any improvement in motor effects, and also was associated with significant side effects, including nausea, vomiting, and Lhermitte's phenomenon. And so an alternative mechanism of introducing this agent was considered, and a open label trial of infusion of GDNF into the putamen itself was completed, and that did have positive effects with limited side effects. And now a larger multi-center trial, blinded, placebo-controlled, is ongoing with infusion of GDNF directly into the putamen of idiopathic Parkinson's disease patients, and so we eagerly await those results. As I mentioned, inflammation has been thought to be part of the pathogenetic mechanism in Parkinson's disease, not as a primary effect, but as a secondary effect which may continue the neurodegeneration produced by another mechanism. And this has been seen not only in animal models, but also in human Parkinson's disease striatal nigral anatomy. Animal models utilizing the antibiotic minocycline has shown that it can reduce the level of degeneration induced by toxins such as MPTP or rotenone. And based on those findings, a controlled trial presently is underway in humans with idiopathic Parkinson's disease, and the results are yet to be published. Finally, mechanisms to enhance mitochondrial and energy function have been focused upon, utilizing creatine, which is a guanidine-derived agent generated in the body, and it's believed that the creatine phosphocreatine system acts as an energy buffer between the cytosol and mitochondria, and its enhancement has been proposed to potentially be protective against the oxidative stress and mitochondrial injury that may occur in Parkinson patients. And again, this agent is being studied actively in Parkinson's disease patients. One area of positive results have revolved around the use of coenzyme Q10, and this study that I will describe was published in 2002 in the Archives of Neurology. Coenzyme Q10 is a supplement that can be bought at health food stores. It is an electron acceptor for complexes 1 and 2 in the mitochondria and acts as a potent antioxidant. And it's been found that coenzyme Q10 levels are reduced in the substantia nigra of Parkinson patients, as well as in platelet mitochondria and in the serum of those same patients. As a result of these findings, a multi-center randomized parallel group placebo-controlled study enrolled 80 idiopathic Parkinson's disease patients who were untreated and had not received antioxidants for 60 days. The patients were stratified into 4 groups, either receiving placebo, 300, 600, or 1,200 milligrams daily, and then they were evaluated with the UPDRS, the Unified Parkinson's Disease Rating Scale, utilizing motor and ADLs at baseline and then at various times after initiation of treatment. The agent was well tolerated and had no consistent side effects. And when baseline to 16 months were compared, utilizing the UPDRS here, and the higher the number, the worse the motor disability, you can see that only patients receiving 1,200 milligrams daily had a statistically significant difference from placebo, suggesting that there may be a neuroprotective effect. However, this remains preliminary, and there has been some speculation that this may also be a symptomatic effect similar to that which was described with selegiline. However, a larger trial is presently underway to look at this agent more thoroughly and investigate the possible symptomatic effects.
What's the score range in UP Europe? Is it 0 to 100?
No, it's each, there are a number of different ratings. 0 to 4 is each scale, and this is the motor score, and there are 12 sub-scores, each with 0 to 4, so 48 would be the maximum for the motor
48,
score.
okay.
Where's the trial that is on?
Where is the trial? There are multiple sites in the Parkinson Study Group. It's an NIH-funded trial. All right, well, we're going to leave the neuroprotective, neurorescue component of the talk and let you go with the understanding that at the present time we have no definitive neuroprotective agent. For patients who are interested in potential neuroprotection, I discussed the use of coenzyme Q10 with them, but with the caveats that I described, and also let them know that multiple trials, as I described, are ongoing looking at certain agents which may ultimately be shown to be helpful in slowing disease progression, but none at the present time have data to support its universal use. So most of the time we're going to be faced with the choice of initial symptomatic treatment, and it's important to understand that just the presence of symptoms should not warrant treatment for the disease. It should be considered only for dysfunctional disability. So it has to be very individualized. The 70-year-old with minor rest tremor and minor bradykinesia who continues to be able to do all of his ADLs doesn't need symptomatic treatment. And it's important to let the patient understand that the presence of symptoms does not require treatment. And that's very hard for many patients to understand, especially family members who see the tremor and think they must be on medicine. If not, something bad will happen. And it's important to take the time to educate them on that distinction compared to other neurological disorders or medical disorders such as hypertension and such. As such, it should be individually based, not a cookbook approach, and so not every patient should be started on the same agent. And it's always important to use the least amount of medicine to reverse the functional disability that is present, not the symptom, and it shouldn't be an attempt to abolish the symptom present, otherwise excess medicine is being utilized. And it's important again to recognize that your treatment may alter the patient's functional disability in the future. At present, there's a multitude of agents that could be utilized as a first treatment in Parkinson patients, including amantadine, the various anticholinergics, selegiline, and in the near future, rasagiline, Sinemet, either immediate release or controlled release with or without COMT inhibition. When it is all combined with COMT inhibition, that now is called Stalevo. As well as the dopamine agonists, and the primary ones that are utilized are pramipexole, ropinirole, and pergolide. Recently, pergolide has been associated with the production of valvular fibrosis, and so patients who are on pergolide most likely need to have yearly echocardiograms to evaluate that potential, or you should choose an alternative agent. When you're determining initial symptomatic therapy, there are 4 issues that should be in the forefront of your mind. Obviously, cost. If the patient can't afford the treatment, the choice is meaningless. The efficacy of the agent that you choose, and then the possible short and long-term side effects. Here's a diagram of cost at a local large San Antonio pharmacy, and you can see that it varies from $9 a month for the use of benztropine all the way up into the hundreds of dollars per month for a standard initial treatment of the various agents listed here. It should be known that most patients who start on Levodopa are on half of this amount, so the typical cost is somewhere around $30 a month, versus some of the dopamine agonists, as we're going to talk about, where the cost may be up to $100 to $300 a month. When you're considering treatment other than dopaminergic treatment being levodopa or dopamine agonists, there are three main entities that you can choose from: the anticholinergics, amantadine and selegiline. The anticholinergics, chemedrine or procyclidine, which is not well known, artane, cogentin, are generally useful for tremor, very unlikely to improve bradykinesia, and we're all familiar with the possible side effects of the anticholinergic agents. I generally do not utilize this class of medicine over the age of 65 or in patients who have other reasons for cognitive impairment, either the disease itself or vascular disease or what have you. Amantadine or Symetril is useful for mild bradykinesia, less so for tremor. Commonly associated with nausea, and in patients who have renal impairment, a myoclonic encephalopathy may occur, and so patients with renal insufficiency should really not be receiving amantadine. Selegiline, as previously commented upon, has a symptomatic benefit mostly for mild bradykinesia, perhaps slightly for rest tremor, but primarily for bradykinesia, but it can induce or worsen sleep disruption because one of its metabolites is further metabolized into an amphetamine derivative or methamphetamine derivative, which can worsen increased sleep latency, vivid dreams, and nightmares. And so if that's a problem in patients, you should consider discontinuing that agent. Most of the time, however, when there's functional disability, we're going to be deciding between levodopa and the dopamine agonists. It's important to recognize that each of these classes of agents has both strengths and weaknesses in regards to their use. Of course, levodopa remains yet still the most effective agent for the motor symptoms, and primarily the appendicular symptoms, the slowness of movement, trouble getting out of the chair, but not the axial symptoms. Hypophonia, dysphagia, postural reflex impairment, freezing, those are really not very well treated by any of the dopaminergic agents. In contrast to the dopamine agonist, levodopa still produces a robust response in most patients, and of course it has a long history of use and safety since the late 60s. It has a relatively rapid onset and is generally well tolerated when slowly introduced. And when the patient does have nausea, it is usually because they have not enough carbidopa. And remember, Sinemet is carbidopa-levodopa, generally 25 milligrams of carbidopa for every 100 milligrams of levodopa. Most patients require 75 to 100 milligrams of carbidopa to completely block peripheral decarboxylation. And so if you're giving the patient 1/2 TID of 25/100, they're getting substantially less carbidopa than is necessary to block the peripheral decarboxylation, which when occurs produces the nausea, orthostatic hypotension, vomiting. And so you can supplement plain carbidopa by giving the patient a drug called Lidosin, which is 25 milligrams of carbidopa, and so you can supplement it without increasing the amount of levodopa. The potential weaknesses of levodopa, again, encircle the potential oxidative stress that dopamine metabolism can occur. And as previously reviewed, when dopamine is released, when you give levodopa, you produce dopamine. It's released and metabolized by MAO into DOPAC, hydrogen peroxide, which interacts with the local iron and eventually produces the oxyradicals, which are theorized to enhance or perpetuate dopaminergic cell neurodegeneration. And so it has been around this theory that the desire to delay the use of levodopa has centered upon. A study that was recently presented but hasn't been published in full form tried to look at this issue as to whether there's a difference in patients who receive early versus late levodopa therapy in Parkinson's disease. And these patients received either levodopa or placebo and were followed in regards to the disease progression. Change in motor scores utilizing the same rating scale, the UPDRS, were utilized first untreated and then versus the final visit. 360 patients were randomized to receive either placebo, 150, 300, or 600 milligrams of levodopa daily, and they received the treatment for 9 months, followed by a 2-week washout with drug withdrawal. And it was found that in patients who received levodopa, there was less deterioration between the baseline untreated versus final visit versus those that had placebo, so suggesting that, at least in the short trial, there was no in vivo evidence that levodopa hastened or perpetuated neurodegeneration. A subgroup of this same study were studied utilizing the beta CIT SPECT scans, again at baseline and then at 9 months after treatment. And in contrast to the clinical findings, patients who had received levodopa were shown to have a greater rate of decline in the dopaminergic cells on beta CIT scans. So these conflicting results, unfortunately, still give no clear determination as to whether levodopa is neurotoxic. However, the clinical study did not suggest that, and there are various reasons that the neuroimaging study may have shown this, this finding that we'll touch upon a little later. Well, in addition to the presumed neurotoxicity that may be associated with levodopa, but is still yet unproven, additional factors are involved in its limitation. That includes the short half-life of levodopa, which may induce pulsatile stimulation of dopamine receptors in the striatum, and the eventual poor response of levodopa, which is probably a result of a disease progression, which results in a reduced ability to convert levodopa into dopamine, and perhaps by this pulsatile stimulation of dopamine receptors by levodopa use. In the end, that results in treatment complications, including motor fluctuations and dyskinesias. And it's important to recognize that there is a typical progression of response to levodopa in Parkinson's disease patients. Early in the disease, patients are given levodopa. They go from the off state into the clinical benefit state, without dyskinesia production. There's a long duration effect, up to 6 hours, and oftentimes patients can skip a dose and notice no real change in their function. As the disease progresses, there's a longer duration of time that it takes for each drug to kick in. The therapeutic window narrows, and so often once the patient peaks, they have dyskinesias in the middle of their dose, the duration of action is diminished, and there is increased incidence for the dyskinesias and motor fluctuations. Eventually, in advanced disease, this time increases even further. The window narrows such that almost all patients by 10 years will have motor fluctuations, the early wearing off, the dyskinesias, and even obligatory dyskinesias, being that in order to get the beneficial response of the medicine, they will have dyskinesias at the same time. And this is the issues and the potential limitations of levodopa use. As I alluded to previously, this levodopa-related motor complications were thought to relate to upregulated steroidal dopamine receptors. However, more and more it's believed that this actually results from pulsatile stimulation of the steroidal dopamine receptors. And two factors lead to this pulsatile stimulation. First is the half-life of the dopaminergic employed. So the shorter the half-life, the more there are fluctuations in steroidal dopamine levels, and so that results in the pulsatile stimulation of the postsynaptic receptors. And the disease severity. As more and more degeneration occurs, this leads to diminished ability to buffer plasma levodopa fluctuations and also levodopa fluctuations in the striatum itself. And that really is what is believed to result in the motor fluctuations and dyskinesias that occurs in almost all patients within 7 to 10 years of disease. Well, what are some strategies to attempt to normalize? Yes? Mm-hmm.
Sorry, but how is it that the fluctuations themselves are thought to result in, is it in a receptor, a more rapid program cell death? Or, I mean, what is the reason that the fluctuation is thought to?
Well, it's a number of factors. One is changes in the receptor population postsynaptically. The second is changes downstream from the postsynaptic dopaminergic cells that results in exocytotoxicity of the subthalamic nucleus. That's presumed to be a secondary effect, not just the effect locally between the presynaptic and postsynaptic receptor, but the pulsatile stimulation of the postsynaptic receptor results in changes downstream, because those cells stimulate the subthalamic nucleus, which then also changes its feedback loop back to the other components of the striatum and the striatal input to the striatum itself. So it's still theoretical, but it is believed that it's a downstream effect, not just a local effect.
Normally, there's not that pulsatility.
Correct. Normally we have a tonic stimulation due to tonic release of presynaptic dopamine, and early in the disease, the ability to buffer the amount of levodopa given to tonically stimulate the receptors occurs, but as more and more degeneration is seen, that ability to buffer the fluctuations in serum dopamine levodopa levels is translated into a similar effect in the striatum.
Yeah, I was going to ask you, when you sort of strategies to basically normalize activity, you're putting two things there: frequent dosing and extended half-life levodopa, medication. So you combine both, or I mean, do you give frequent extended half-life medication, or do you use immediate release and leave the extended release?
Right.
How do you do that?
Okay. Well, first, obviously, you could give more frequent dosing of the immediate release medication. Other modalities that have been used experimentally have been duodenal infusions, continuous duodenal infusions of levodopa. Liquid levodopa, where patients take hourly levodopa. I published some studies utilizing liquid levodopa. Nothing looking at disease progression, was just a clinical study looking at improvement in motor fluctuations that they were having already. Those are three options. And intravenous infusions have been studied, and in MPTP model of Parkinson's disease and patients who have idiopathic Parkinson's disease, those receiving either continuous duodenal infusions or intravenous infusions do not develop these motor fluctuations. And so obviously that's not something that we can utilize in our day-to-day clinical care, but just to give you an idea of the scope of things that have been utilized. I'm going to talk a little bit about what you can do in clinical practice, but I wanted to go over this first. In addition, there was excitement over the use of the controlled release formulations that came out about a decade ago. And in addition, more recently, the ability to combine a COMT inhibitor with levodopa. And then at the end of the study, we'll talk about, at the end of the talk, we'll talk about the dopamine agonist. Looking at the potential benefit of the CR formulations, it's important to recognize that the CR is an erodible matrix, and studies have shown that utilizing CR formulations prolong plasma levels and presumably brain levels, although this has not been proven, and theoretically may result in a more tonic activation of dopamine receptors. These tablets take about 3 hours to fully dissolve, and although you can give the medicine less frequently, it does result in a 30% higher dose need by patients because of the bioavailability of the CR formulations. A study that looked at whether there was a difference in patients who received immediate release versus controlled release Sinemet from onset was published in the late 1990s. This study utilized 618 patients who were followed 5 years. And unfortunately, there was no difference in frequency of motor fluctuations or dyskinesias in patients who were either randomized to immediate or controlled release formulations of Sinemet. Although the only statistically significant finding was that the patients who were on CR had slightly better ADL scores. So not an option really to try to reduce the occurrence of motor fluctuations in your patients. More recently, the COMT, both entacapone and talcapone, although talcapone is rarely used now because of the potential of fulminant hepatic failure. So generally entacapone or Comtan is used either by itself or now in combination with levodopa in an agent called Stalevo. And it has advantages over the controlled release formulations in that it doesn't delay the absorption of levodopa and may theoretically prolong on without increasing dyskinesias. However, the studies that need to be done to look at whether patients who are started on Comtan early versus not, both groups being on levodopa, haven't been completed yet. And so we don't know whether this is a mechanism of potentially reducing the onset of motor fluctuations and dyskinesias.
So you could give the sentiment with
At the present time, if you're going to start levodopa, although there aren't studies to support its concomitant use, the theory that you can maintain more stable plasma levels and in turn result in a more tonic stimulation of postsynaptic receptors would suggest the use of COMT inhibition along with levodopa. And now it is simply done.
with the sentiment, though, with the carbidopa, the levodopa.
Correct,
carbidopa.
correct. There's no utility to give Comtan without levodopa. Okay.
And carbidopa.
Right, right. You still need to give carbidopa because you don't block peripheral decarboxylation with Comtan. Much of the interest, however, has focused on potential rationales for the use early of dopamine agonists, and this revolves around their longer half-life, which would result in a more phasic stimulation of those postsynaptic receptors. It would potentially allow you to limit the use of levodopa. However, it would be important to establish that they are effective as monotherapy. It wouldn't matter if they have a longer half-life and allow you to use less levodopa if they're not effective as monotherapy, and if they don't delay onset of motor fluctuations. So these two areas have been evaluated recently, and then even more recently, the dopamine agonists have been looked at for their potential neuroprotective qualities, and if present, would obviously suggest that they would be the agents of choice to initiate therapy with in your Parkinson patients. Here's a study that was published in the late 1990s using pramipexole versus placebo. Patients were randomized here at baseline. There was a dose escalation phase and then a maintenance phase. And in comparison to placebo, pramipexole or Mirapex was statistically superior in reducing the motor score starting at the fourth week of therapy and extending all the way through the maintenance phase. Additionally, in the motor scores, a similar response was found, suggesting obviously that these agents are, this agent is effective as monotherapy.
Would you judge those to be, I know they're statistically significant, are these also clinically significant scores?
Well, let's see, we can go back here. Okay. Yep. If you look at the motor scores here at the end point, motor score of 20 versus 14, 6 points lower than their probably placebo group here. That could be the difference between being able to get up out of the chair by themselves versus needing assistance, or severe bradykinesia versus mild bradykinesia. So a score of 20 versus 14 is fairly substantial.
And what's the ADL scale there?
The ADL is a large group of questions with a maximum score of 40, which deals with speech, swallowing, various factors. So it's more a diffuse scale. This is another way to look at the benefit of pramipexole. Here looking at the probability of patients being able to remain on pramipexole without levodopa, and by 4 years after randomization, nearly half of the patients were able to continue on pramipexole monotherapy without levodopa, again supporting their use as monotherapy, its use as monotherapy. This is a similar study utilizing ropinirole or Requip versus levodopa, and only patients who had significant disability, that being a Hoehn-Yahr scale 2.5 or 3, that being that the patients have a postural reflex impairment and bilateral symptoms. 2 is bilateral symptoms, 3 is postural reflex impairment with bilateral symptoms. Only at that stage of the disease was there a statistically significant difference in patients who could be maintained on ropinirole without levodopa. And this, similar to the Mirapex study, again, almost 40% of patients who were randomized to ropinirole were able to remain on monotherapy at 5 years. All right, well, we've established that both ropinirole and pramipexole are useful as monotherapy. Well, what kind of effects can be expected insofar as the onset of motor fluctuations? And this study, as a part, an extension of the initial study, was published in the New England Journal in 2000, and again looking at all patients regardless of levodopa supplementation. So this is the group that received ropinirole with or without levodopa, or levodopa monotherapy, and the time of onset of dyskinesias, and again at nearly all levels after 2 years there was a statistically significant difference in the onset of dyskinesias, and a greater difference when monotherapy was utilized with ropinirole only versus monotherapy with levodopa, both at 3, 4, and out to 5 years. And this is the exact same kind of study done with Mirapex, again looking at the percentage of patients experiencing any dopaminergic complication, just wearing off, and dyskinesias out from randomization up to 700 days, and all were statistically significant in that pramipexole had a lower likelihood of inducing motor fluctuations versus levodopa. Well, in addition to their effectiveness as monotherapy and their ability to delay the onset of motor fluctuations and dyskinesias, there has been some evidence of neuroprotective effects of dopamine agonists. First of all, they are known to have antioxidant properties, and as a result of reducing levodopa, they decrease the turnover of levodopa and so reduce the generation of free radicals by the metabolism of dopamine, as previously reviewed in the graphic on the earlier slide. Additionally, the use of the dopamine agonists may diminish excitotoxicity due to overactivity of the subthalamic nucleus that occurs in Parkinson's disease related to the more pulsatile stimulation that levodopa produces, as we discussed a minute ago. And additionally, certain studies have demonstrated an anti-apoptotic effect in cell models utilizing the dopamine agonists, and suggesting that these agonists can protect dopaminergic neurons from a variety of toxins, both in vitro and in vivo models. Well, symptom reduction versus disease modification has been something that has been difficult to show both in pramipexole and in ropinirole, and it's important yet to decide whether these agents have any disease-modifying properties outside of their ability to be effective as monotherapy or delay the production of motor fluctuations. The clinical rating scales that are used to assess disease progression are generally confounded by the treatment effects of medication. We've seen that from the initial studies of selegiline. The underlying disease process, however, continues unabated despite the clinical improvements that have been seen in the various clinical trials. And it's also important to note that a medication that may slow progression may have little immediate impact on symptoms, and so a different way to evaluate whether these agents do have neuroprotective effects needed to be designed. And that resulted in 2 clinical studies that were aimed at testing the capacity of dopamine agonists to modify the rate of disease progression in newly diagnosed patients with Parkinson's disease. And they utilized the imaging markers as primary endpoints, and the 2 that I touched upon earlier in the talk. That involved 2 studies named CALM-PD CIT and REAL-PET. In the CALM study, patients were randomized to either pramipexole or levodopa. In the REAL study, they were randomized to ropinirole or levodopa. A striatal CIT uptake on SPEC scans were utilized in this study, and the rate of decline in striatal fluorodopa uptake on PET scans were utilized in the REAL study. This mechanism utilized the determination of the dopamine transporter density at baseline and various times during the 4-year trial. This study utilized the fluorodopa at various times over an extended trial. Both studies allowed patients to be supplemented with open-label levodopa. And so when we, again, just looking at this graphic again, the levodopa fluorodopa study, again, utilized this mechanism where the fluorodopa is taken up, converted to dopamine, and then caught in the dopaminergic cell, and then studied with PET scanning. The CIT attaches to the presynaptic dopamine transporter and is then detected on SPEC scan. And when we look at the combined data here, this is over 24 months for the ropinirole and 46 months for the pramipexole. Levodopa is the open circles, and the dopamine agonists are the closed circles. And this axis is the percent decline in the imaging marker. And so you can see in comparison to levodopa in both studies, there was a 36 and 35% respective difference in the decline of the imaging marker. So as the disease, as time went on, there was an addition, a declining number of dopaminergic cells in both studies. However, neither study showed a corresponding clinical benefit, being that there was no clinical difference between those patients receiving levodopa or the dopamine agonist. Well, how could we interpret the results of this study? Well, on the surface, it could suggest that these agonists do slow the rate of cell loss in the substantia nigra, similar to those effects that were found in the laboratory. What about the absence of the clinical correlate? Well, some have suggested that these studies were too short, only being up to 4 years, and that these agents both had powerful symptomatic benefits in the beginning of the disease, and so the difference could not be equated to the difference in the markers that were found. Another potential interpretation is that levodopa is toxic. However, at present time we have no in vivo evidence, and to the contrary, the L-DOPA study that I presented earlier showed that there was no difference when patients were stratified early to levodopa versus placebo. One confounding issue that has to be taken into account is that the effects on these markers may actually be due to a difference in the capacity of both levodopa and the dopamine agonists to regulate the dopamine transporter and fluorodopa metabolism. And at the present time, there's mixed data both supporting and in opposition to this potential confounding effect. And so at the present time, additional studies really need to be done to answer the question as to whether these agents have neuroprotective effects. Well, what conclusions can we make then today? First, as previously stated, there is no definitive neuroprotective agent that must universally be used in your Parkinson patients. And those patients that desire some potential neuroprotective agent, consideration for coenzyme Q10 at 1,200 milligrams daily would be useful to discuss with your patients.
Can I ask you a question? I have never, I still don't really adequately understand why the results from the data top and then the subsequent trial where allegedly was paired with levodopa, why that hasn't resulted, because those are both strongly positive studies. why that hasn't resulted in a more aggressive use of that agent in early therapy. I just don't understand that. Maybe you can help me understand.
Okay. Well, the first issue was that the agent was found to have a symptomatic effect.
Right.
Okay, and the benefit only lasted and was maximal at a year. And so you would think that if it had neuroprotective effects, that the benefits would go beyond 1 year of therapy. That's the first issue. The second was that a subsequent trial, or a retrospective, showed that in a study in the UK that patients who were on L-Dopa had an increased mortality rate compared to Parkinson patients who were not on L-Dopa, and those two combinations resulted in almost the abandonment of its use. More recently, the focus on these agents' ability to interfere with apoptosis has brought back into light their potential neuroprotective effects outside of the confounding issues that were brought to light after the DataTop study. So it's not a universal use by movement disorder physicians, but with the new data with rasagiline, some of the laboratory studies utilizing L-Dopa and its anti-apoptotic effects, I think you'll see more and more literature supporting its use again.
What about cost, about profit? Was it too cheap of a medication? Or was it
No, it was fairly expensive at 5 milligrams twice daily, and so there wasn't any implication that there was a pharmaceutical industry reason not to utilize the agent, or it was more expensive than the dopamine agonists. And I think there's a scheme, your diagram shows that it's actually fairly inexpensive, and now it's available in generic. So.
It's just sort of complicating the treatment of the depression that a lot of the patients have, because if you're on the MAO inhibitor, you can't give them an SSRI.
Well, I mean, an MAO-B,
That's the big
usually at
difference.
5 milligrams BID, there isn't, there's actually been studies looking at that in Parkinson patients, and there wasn't any significant effects when Paxil was used
There's
with,
still sort of extreme sort of contraindications in the packaging.
right.
No, I understand that. It just seems like as a combination of, I mean, that I understand that you have confounding between symptomatic effects and disease progression. But it is one of the few drugs that's ever been shown to sort of delay onset of ADL deficits. And so I've always been confused about that.
Well, those are the two reasons.